Hi, everyone. It's my pleasure to welcome Cristina Canavesi from Light Top Tech to the Colloquium today. I first met Cristina when she was in freeform optics, and she was doing freeform optics and illumination. She continued in that, was the administrative director for the CFO, the Center for Freeform Optics in Rochester. But her passion was always to do biomedical optics. And I've been always thinking of inviting her here, and she just told me that they've recently finished their system, and so it was the perfect time. Her passions took her into a system that uses what they call OCX, and it integrates optical coherence tomography and Gabor microscopy. We are so happy you could come here. Here's our certificate of appreciation, and it comes with our little pin up there from the college.
Thank you.
And
Beautiful.
the floor is yours, Christine.
Thank you so much. Let me know if the audio has any issues. Thank you so much, John and Florian, for inviting me. I'm very happy to be here. So I wanted to give you a short background of my company, Light Top Tech. It was started in 2013, and we are a graduate of the I-Core program, both with the National Science Foundation and National Institute of Health, and of the Luminate Accelerator. Acknowledged funding from NSF and NIH in the SBIR program, as well as a number of local programs in New York State and in Rochester, where we are based, and where this was what it looked like yesterday when I left. So yeah, we're pretty much on the opposite side of the country, but we have strong ties here to Tucson via Janique Rowland, who was a PhD student here at the and was the 2019 Alumna of the Year. So the motivation for our work is to enable optical biopsy, which means being able to image down at the cellular level in a completely non-invasive, non-contact way. So today I'll be talking about motivation, what technology can enable that, Gabor-Domain optical coherence microscopy and optical coherence tomography, and integrating those two in OCX. And I'll describe a few applications which have resulted through some clinical studies for cervix, where we demonstrated the capability of imaging down to the cellular level. Another application is skin, where we can enhance the structural imaging with functional capabilities. And then another application is in the corneal imaging, where we can, again, enhance the information from the imaging with machine learning methods to extract quantitative information from the 3D images. So the motivation is to enable optical biopsy, and this really requires, has some stringent requirements from the optical imaging instrumentation point of view. So we're really interested in looking down at the cellular level. So this means we need to be able to resolve down to the micrometer scale. We want to do this in 3D over as wide a field of view as possible. Definitely bigger than what typically is done with microscopy, which is typically less than a millimeter. And we want to be doing this in vivo in tissue, so in a non-invasive manner, which is why using optical technology has so many advantages. So to get you oriented in what this technology is and how it fits into the space, there's a chart that shows a number of imaging modalities in terms of two key parameters. If we're talking about optical biopsy, there's lateral resolution on the vertical axis. That means how small of a feature you can image. And on the horizontal axis, we have imaging depth, so how much can you penetrate inside of the tissue. And as you can see, there's a natural trade-off between these two parameters, and these methods all fall along the diagonal. So to start, so the goal that we have is to being able to image at the micron scale over a depth that's clinically relevant, so at least millimeters, ideally. So to start, there's some techniques that do not have sufficient resolution to be able to see down at the cellular level. However, they have good penetration. So the first example is ultrasound, and we have here an image of the cornea, so the front part of the eye. With ultrasound, you get this kind of cross-sectional view. It has excellent penetration in the body, not sufficient to visualize at the cellular level. So OCT, optical coherence tomography, was invented in 1991, and it can be seen as the optical equivalent of ultrasound. So it uses optical wavelengths, so we can get down to more of the micron scale, sub-millimeter scale. You give up in the penetration, so the penetration is limited to millimeters. And this is the typical presentation of an OCT image. So it's a depth cross-section. You have depth, the vertical, and then you have the lateral dimension. And OCT typically has a lateral resolution in the tens of micrometers. So again, not sufficient to visualize cellular details. Then if we go to the opposite part of the chart, we have microscopy techniques, which have beautiful cellular and subcellular resolution, but are limited in the depth. So confocal microscopy has a beautiful lateral resolution. This is a confocal microscopy image of the endothelium, which is a single layer of cells that lines the posterior surface of the cornea. And you can see the beautiful detail of the hexagonal pattern of these cells. But again, the limitation really is in being able to bring this to an in vivo capability. Another limitation is the field of view. This is less than a 0.5 millimeter field of view. So optical coherence microscopy is a variant of OCT that was introduced to break the lateral resolution limit of OCT. So it can achieve resolutions on the micron scale by opening up the numerical aperture. So you can get, again, this is an example of the endothelium where you can resolve the cells there. The disadvantage when you open up numerical aperture, as we'll see in more detail later, is that you lose in depth of focus, maybe a few tens of micron depth of focus. So that's really not applicable to a clinical environment. So that brings us to GDOCM, which is a variant of optical coherence microscopy where we can maintain that high resolution throughout the depth. So you can truly obtain 3D images with the same 2 micron resolution, both laterally and axially. And so what you obtain is, you get a 3D image of the depth cross-section. The typical view of OCT is obtained, but as well the microscopy view, the en face, so the orthogonal in the orthogonal plane. You can visualize those cells down to the micron scale, and you're not giving up on the depth capability. So with OCX, well, there's some, so this was a research tissue, so there's some defects in the actual cornea. So with OCX, we bring together OCT capability and GDOCM in a single instrument. So you can image with a wide field of view and then go down to the cellular level. So let's go a bit more in detail about these two technologies. And I will start by providing a brief overview of OCT. As I said, this technique OCT was invented in 1991, but it builds on low-coherence interferometry, which had been around for a while. And the first implementation of OCT is what is called time domain OCT. So the principle of OCT, as I said, is similar to ultrasound in that you send a beam through the tissue and you detect what is reflected or scattered back from the tissue. Now with ultrasound, you do a time of flight measurement. Since we're dealing with optics, with optical wavelengths, it's too fast to make a time of flight measurement. So we build an interferometer as shown here. So I have a light source gets split between the sample, which is what we're interested in imaging, and a reference arm, which has a mirror. And in time domain, the mirror gets scanned at different depths to probe corresponding different depths in the sample. And then you detect so the light gets reflected back and you detect the interference. And the electric field of the interferometer is the sum of the fields from the sample and the reference. And you're measuring the output intensity is proportional to the square of the field. So if you're scanning the mirror in the reference arm to scan the length of the reference arm, you obtain interference fringes as a function of time when you're using coherent light. Now, if you're using low temporal coherence light, which means you have statistical phase discontinuities over a distance that's known as the coherence length, this means that the interference between the two arms is only observed if the difference in those path lengths is within the coherence length of the light source, which is directly correlated to the bandwidth of the light source. So by doing this, you can really localize where your reflection is coming from inside of the sample. And using that information, you can build an image. So this is the principle of the time domain OCT. Now, one of the big advances that that came to the field of OCT is Fourier domain OCT. So in this case, the reference arm length is fixed. We're not scanning the reference arm anymore. Because what happens is that different layers inside of the sample, so different depths, cause a different modulation of the spectrum. And so we're able to reconstruct the different depths directly from the spectral information. So we're acquiring not anymore the time domain signal, we're acquiring the spectrum of the light. And with the Fourier transform, we obtain the depth correspondence at the bottom here. So one very important characteristic of OCT is that the axial resolution, so the resolution along the depth, and the lateral resolution are decoupled. And the axial resolution shown here really depends on the bandwidth of your light source. So the broader the bandwidth, the better the axial resolution. Lateral resolution depends on the optics in your imaging system. So it depends on your central wavelength and your numerical aperture. And so the advantage with OCT is you can really tailor these two parameters independently depending on what you're trying to achieve. And with OCX, where we have OCT and GDOCM that have different lateral resolution, we can still leverage the same advantage of high axial resolution with the same light source, and then have two different modalities to probe different scales with the lateral resolution. So in any imaging system, there's a natural trade-off between your lateral resolution and the depth of focus, as I was mentioning earlier. If you have a high numerical aperture, you're able to really benefit from a tight spot, but you're losing in your depth of focus. In OCT, typically, we operate a lower numerical aperture so that your depth of focus spans, even the millimeter scale. So that way you're able to image in a single shot, you get your entire volume that you're trying to image. But in order to obtain that better lateral resolution, you need to increase the numerical aperture. So of course, there's different spaces where we'd like to be operating at. So this is just plotting the lateral resolution and the depth of focus versus numerical aperture. So we'd really like to be at a very low, micron scale lateral resolution. That means high numerical aperture, but we also want to be probing the millimeter scale in terms of depth of focus. So that means a very low numerical aperture. So these two spaces we don't intersect. So this is really how GDOCM was introduced to overcome this fundamental limitation. It was invented by Jeanette Roland, and it incorporates a liquid lens inside of the microscope. So we have a high numerical aperture. We open up the numerical aperture. Depth of focus becomes shallow, but with the liquid lens, we refocus at different depths inside of the sample, and then we acquire multiple volumes that are fused together. So I have some visuals to illustrate this principle. So there's an example on a human finger, just 3 examples showing how we're moving that focus plane further deeper down in the tissue. So we acquire these 3 volumes, and we extract the region that's in focus. So the region of higher contrast is where it's focused. We extract that region, and we fuse them together in a single volume so that we're maintaining that high lateral resolution throughout the depth. And that way we can achieve micron-scale resolution isotropically, both laterally and axially through in 3D. So that is an example of the finger getting down to cellular resolution. So that brings us then to the concept of OCX, which we've recently introduced as combining the capabilities of OCT over a wide field of view and GDOCM down to the cellular level in a single instrument. That means you can probe the sample at different scales without having to reposition the sample. So OCX is a new type of imaging instrument operating at different scales, starting with the wide field of view of OCT. This is a cornea, for example, and then moving seamlessly into the microscopy view down to the cellular level. And these are the endothelial cells at the bottom of the cornea. So OCX is the first instrument that combines these 2 methods and integrates them in a single compact portable format, desktop format system. So we can obtain non-invasive structural imaging on the cellular level that's comparable to histology, as we'll see later. This also makes it possible to combine, since we're obtaining these data sets at very high sampling, we can combine them with machine learning methods to automatically extract features of interest. And we can also apply functional methods on top of the structural to obtain additional information from the tissue. So this is kind of an overview of what we'll be looking at later in the talk. So this is what the system specifications look like today. We are operating in the near infrared around 860 nanometers. We have an axial resolution in tissue of 2.2 micron. That's the same in both modalities, OCT and GDOCM. And then the lateral resolution is less than 3 micron for the GDOCM mode and 13.5 micron in the OCT mode. Field of view in OCT mode is 10 millimeter, and GDOCM is up to 2.5 millimeters. So here, just to kind of compare these capabilities to what has been available commercially so far within the OCT realm. So on the left is an image acquired with Leica by Optigen OCT, which is pushed to its limits to obtain these kind of images. These are images of a retinal organoid, the same retinal organoid acquired with the 2 systems, this OCT system, and then with our GDOCM modality in the OCX system. So you can appreciate the higher level of detail that we can obtain in the various layers of the organoid, such as in particular, this outer layer, better clarity and better resolution. So the combination of the OCT and GDOCM modalities in OCX is very well suited for imaging organoids so that you can start with a wide field of view OCT view and then identify regions of interest, which you can examine in detail with the GDOCM. So for today, I'm going to be talking about 3 applications. The first one is establishing the comparison between GDOCM and the gold standard of histopathology, in this case for cervix and cervical intraepithelial neoplasia. Next, we'll look at how the structural information can be further enhanced with functional modalities to, in this case, to extract vasculature in skin. And then we'll look at how we can apply machine learning to automatically segment cells in the cornea. So the first application is cervical cancer prevention. There's been a lot of progress that has resulted in the state of care with cervical cancer screening programs and HPV vaccination programs. They've had a significant impact in the incidence of cervical cancer. However, in the US, cervical cancer still affects about 13,000 women per year, with approximately 4,000 cancer-related deaths. Patients with abnormal cervical cancer screening are referred to colposcopy for diagnosis and management. Colposcopy uses a binocular microscope to visualize the cervix and identify abnormal areas. Abnormal areas are then biopsied and sent for histopathology. The histologic evaluation of punch biopsy is the gold standard for identifying cervical intraepithelial neoplasia. The biopsy results determine whether the patient needs treatment by excision of the transformation zone with a procedure that's called LEEP, loop electrosurgical excision procedure. The current screening process, however, suffered from several limitations. The screening guidelines have changed with HPV testing, so colposcopy volume is decreasing, which means that provider skill is decreasing. Most providers are doing less than 50 cases per year. So reproducibility is poor and sensitivity is low. It's been shown that taking a single biopsy targeting the worst appearing lesion may miss up to a third of precancerous lesions. So achieving an acceptable level of sensitivity requires taking between 2 and 4 biopsies. So this obviously raises the question if optical imaging can provide a better solution to this sampling issue. So in this small study, our goal was to determine if GDOCM can distinguish between cervical epithelium and stroma and cervical intraepithelial neoplasia. And the goal of the study was to compare the GDOCM images with histopathology. So the study was done ex vivo on 5 women undergoing LEEP procedure. We actually did this in the room next to the operating room. So the specimens were, well, they were tagged for their, not for us, they normally do this. So we did the imaging and then the samples were sent to histopathology and routine sample preparation. So we had less than 20 minutes with each sample. We didn't want to modify the standard of care. And so we imaged at different locations on the sample. So here's an example of a B scan of one of the specimens. And this is the B scan, is the cross-sectional view. It's also the typical view that you get with the histopathology. And in the GDOCM images, we achieved cellular resolution, and so these are individual epithelial cells. We were able to identify the junction between epithelial and stroma, and we also saw hyperkeratosis, which is a nonspecific feature seen in dysplasia. And we noted this in 62% of the scans. Other findings include papillary structures and stromal vessels. So with histopathology, the grade of cervical intraepithelial neoplasia is determined by assessing density changes over the epithelial layer. And using the same method, a pathologist also graded the GDOCM images. And these are some examples that were graded as CIN1 and CIN3. So here's an example of a CIN3 grading for GDOCM and the corresponding histology. In the GDOCM, it was noted that there was an increased density leading to the CIN3 grading. So in summary, for this application, we've validated the imaging technology against the gold standard of histology. The next steps, which are still to be conducted, will include fitting the imaging in vivo within the clinical workflow and developing numerical methods to grade the images. So let's switch now to the skin dermatology application and vascular assessment with OCTA. OCTA is a technique that has been introduced as part of, on top of OCT and has been gaining more traction in the last 10 years or so. So the principle is that OCT is a structural imaging. It detects what's scattered back from the tissue. Now, in tissue, there's when you're doing in vivo, there's motion. There's things that are in motion. So blood flow, for example, is not static; it's flowing. And if you conduct repeated measurements with OCT at the same location over time, you can extract what is static and what is dynamic. In this case, the blood cells that are flowing. So, so the concept is to acquire repeated scan of the tissue and then high-pass filtering and post-processing to extract the large variation that come from moving blood cells. And the advantage of this method is that it's a label-free technique. There's no exogenous dyes. It's completely non-invasive. However, there are some challenges coming from the fact that we are making this measurement in vivo. Motion is always a challenge, especially when we're dealing with very high resolution, such as with GDOCM down to the micron scale. So this makes it more challenging because of the higher sampling as well that isn't required when we have the higher resolution, which means that it takes longer to acquire. So in order, we were able to overcome the motion challenge just by modeling the motion as part of the image processing. So this is the processing pipeline that we implemented for OCTA, OCT angiography. The repeated scans are modeled as a combination of unique terms and common terms. So we did this through iterated factor analysis that minimizes the log likelihood probability. So after the factor analysis, the high order common terms are back transformed into the space domain and then summated and log compressed. So essentially, the OCTA is a high-dimensional two-class classification task that differentiates the static structure and the blood flow, in which the linear fitting may not well approximate the classifier due to nonlinear correlations coming from the time interval, flow speed, particle concentration, etc. So in order to deal with this issue, we added a subnetwork through a list of nonlinear operations, including summation, of the original frames, log compression, medium pooling, rescaling, calculation of power ratio, and most importantly, a reverse sigmoid transformation by a reverse sigmoid function. And finally, the OCTA map is obtained through a pixel-wise multiplication between the blood flow image from the linear operations and the map of the nonlinear correction. And we named this method ultra-high resolution factor angiography. So this is what the workflow looks like for the image acquisition and processing. So we acquire with the OCX system images, 5 repeated images at the same location, 5 repeated frames per location. Then the first step is to perform motion correction with a tool that we developed. It's called Frame Align. Then we perform OCTA processing and visualize the images in the Viewer 4D, which is our visualization software that you've been seeing throughout the presentation. So here are some examples of imaging the nail fold. This is an example of the GDOCM modality imaging of the nail fold of a human finger. These are the corresponding en face vasculature images. This is our OCTA result. And at the top, we compared it with a conventional dynamic speckle variance, OCTA processing. So one of the advantages of our approach, as you can see, is that the motion artifacts that cause these horizontal lines are largely suppressed because of this of our approach. So and you can visualize these U-shaped hairpin capillaries. And so the size and scale correspond very well in the literature. There is reported that there's 9 to 12 of these capillary loops per millimeter in the nail fold. And so you can see this is the structural image, and then you're able to extract the vasculature from that image. Here's another example. We imaged just the fingertip. And on the left is a normal. On the right is there was a knife wound that was imaged. And here at the bottom are some results of the en face. Again, the structural, conventional, dynamic speckle variance, OCTA, and our factor analysis approach. So you can appreciate the improved signal-to-noise contrast with our method. And we noted that our factor analysis approach reduced motion artifacts by nearly 50% on average compared to the conventional approach when evaluated on local differences. And also we noted in the wound case that there was biofilm and interstitial fluid that accumulated in the wound. So our approach was shown based on factor analysis, was shown to reduce motion artifacts that highly impact in vivo imaging, especially when we're dealing with high resolution. And the motion artifacts were in fact reduced by nearly 50% on average compared to conventional OCTA approaches. So this angiography approach is very attractive because, as I mentioned, it's label-free. It gives us functional information really without having to give up anything. It's completely non-invasive measurement. So next, I want to talk about corneal imaging and in particular, seeing how it can benefit from integration with machine learning methods. So at iBanks, iBanks are responsible for collecting and evaluating corneal tissues from donors, prior to transplant in order to qualify and identify which tissues are suitable for transplant and for which specific types of procedures. And at iBanks, the corneal tissues are typically stored in these containers. They're called viewing chambers, which contain also a medium to keep the tissue alive. So with our system, we're able to image through the container without having to expose the tissue to the outside environment to avoid any contamination. And here's an example of the OCX imaging. So on the left is the cornea. As you saw some videos earlier. So we have the wide field of view capability with OCT. OCT is in use today at iBanks only to measure thickness. So we have that capability in the OCX, but we also have the microscopy capability that lets us examine the entire tissue throughout its depth down at the cellular level. And in particular, we can look at different layers of the cornea. So this is the 3D volume in the GDOCM mode. So this is the B-scan, the cross section, and we can identify the different layers of the cornea. And then we can look in the en-face view, the orthogonal plane. We can look at the epithelium, resolve the epithelial cells there. In the stroma, we can identify keratocytes. And in the endothelium, we can visualize the endothelial cells. So endothelial cells are a very important metric of the health of the cornea. And iBanks quantify the density of endothelial cells and provide that as a metric to surgeons who request the tissue for transplant. So in order to visualize the cells, so let me go back. So this is the en-face image at the endothelium. And as you see, the cornea has natural curvature. So when we're looking at a single plane here in the 3D image, we only get a portion of the image that contains the cells. So the first step we did in the numerical processing was to automatically segment the endothelium from the 3D image, and then use that to numerically flatten it so that we can visualize all the cells in a single image. Now, then the next step is to count the cells in that image. So to start, so we implemented a convolutional neural network to do that. So to start, we needed manually annotated data. So these are some examples of the images that were acquired and manually annotated. In total, we worked with 180 images from 6 different corneas that were imaged at 5 different locations each, and each location was repeated 6 times, so it comes out to 180 original images. And these are the results of the manual cell counting for the 6 different corneas at 5 different locations. And you see there's what's shown here is the endothelial cell density cells per square millimeter. And we can assess the standard deviation that results from the 6 repeated measurement at each location that's indicated by the error bars here. And so we can assess the mean repeatability error as the standard deviation, the ratio between the standard deviation and the endothelial cell density and the mean count. And the values at the bottom show the mean repeatability error that was under 2%. So with those with that data, we implemented machine learning using the manual annotations as the gold truth. So we trained a convolutional neural network to automatically segment the images of the corneal endothelium, so to automatically detect the cells and identify their borders. We used VGG16 convolutional neural network, and the training was done on 150 images out of 180, keeping the 30 for testing. And this was done this was repeated 6 times in the leave one out cross-validation strategy. So here is an example of the results. So on the left, we have the original flattened image of the endothelium. On the right, we have the results of the counting. And we have the manual counting in red. The teal is the automated counting, and the white are the ones that were found in both methods. So in some cases, you can see that the automated method was better at finding cells than the manual, which is very encouraging, and it is not too surprising because of the fact that it's a manual process. So the motivation for this work is that by implementing this fully automated method, you can obtain a completely unbiased assessment. One of the challenges today at iBanks is this is done manually. So this means that there's bias because the operator tends to pick the cells that look best. So that kind of skews your count and doesn't provide really objective assessment. So the results of the comparison between the manual and automated counts. The average difference in cell counts was 0.3%, and the correlation was at an R squared of 0.94, and these results were statistically significant. We also then, to validate the automated procedure, we also imaged 10 additional corneas and compared the counts from the automated, from the GDOCM images and then automated counting to the counting that's done at the iBanks using specular microscope. And these are the results. The average difference in the cell count was 3.7%, and had an R squared person correlation of 0.91. This is an example of a picture that's of the specular microscope that's used at iBanks. Has a small field of view. It also only images the endothelium. With our imaging, we can image the entire 3D cornea and then assess the cells on a larger scale and also do the automated counting. So this brings new capabilities and brings an automated and unbiased assessment of cellular structures. Just a minute. So moving on, so that was obviously done on donor corneas, so ex vivo tissue. Moving towards in vivo corneal imaging, we've conducted the study on mice in vivo corneal imaging. This is a picture showing the working distance, so it's non-contact measurement. Now the challenges, as we've discussed for the skin imaging, come from the fact that we're imaging in vivo, so there's motion that we have to deal with. Motion artifacts are caused by heartbeat and breathing. The mice were anesthetized, but you still have breathing and heartbeat artifacts, which are quite significant in mice. You can see the rates here. So this is an example of the in vivo imaging of the cornea. So when we're imaging, I mentioned earlier with OCT, you get an entire depth scan at a single point, and we're scanning in both dimensions. So we have a fast axis of the scan, and we have a slow axis. And along the slow axis is where you pick up all the motion, which shows up in the en face view with these horizontal artifacts, which is what we had seen in the skin example with the conventional OCTA approach, where it still had motion artifacts. So this is what the images look like before the correction, and this is what they look like after motion correction. So we're able to recover the cellular resolution and visualize the endothelial cells. And here are some more images of the mouse imaging. So the OCT wide field of view image, and then the GDOCM capability down to the cellular level. In this case, so we can see epithelial cells in the epithelium, endothelial cells in the endothelium, and also corneal nerves, which was what we were actually interested in evaluating in this study. We compared normal mice with diabetic mice, and were able to assess a reduction in the nerve fiber length and nerve branching in diabetic versus normal mice, which was consistent with what's reported in the literature. The reduction we observed was greater than 30% in the diabetic mice. So these capabilities really bring new ways of assessing these parameters in vivo. A lot of these examinations are done sacrificing the animal, whereas now it's possible to do these investigations longitudinally on the same animal over time. So in summary, we've brought optical biopsy with the dual modality OCX, enabling 3D in vivo imaging of tissue with cellular resolution, and combining that with a wide field of view OCT in order to first identify the region of interest and then examine it down to the cellular level. And the advantage of the system is that it can be very easily enhanced with additional modalities, such as we've seen, functional modalities with OCTA, as well as applying machine learning to these high-resolution 3D data sets in order to extract parameters and metrics of interest from the tissue and provide an unbiased assessment. And so there's been a number of very talented people that have contributed to the development of this technology, from technical, scientific collaborators, manufacturing, clinical, preclinical collaborators. A lot of them are shown here in no particular order. And with that, I'd be happy to answer questions.
Any questions?
There are some. Yes, we haven't tried that yet, but there is interest in applying the OCTA. Yes, yeah.
See the nerves, but not the blood vessels.
Where we were looking at the time, yes. Yeah. So maybe I'll just give you a preview. So we have we've developed a clinical version of, it's not a clinical system, but we've developed this headrest for a clinical study on corneal imaging, which is underway at Pascal Palmer Eye Institute, and we'll be looking at 4 different patient groups, and we have corneal infections, dry eye, fuchs dystrophy, and then ocular surface neoplasia, where there's definitely interest in exploring the vascular implications with this method. The dry eye will be more on the nerves. Fuchs dystrophy is for the endothelial cells. So I know your initial question was what are those holes? So those are some defects in cornea that show up at the endothelial level.
Yes, moving on. Yeah, yeah.
Can you go back to your factor angiography
Mm-hmm.
or angiography? How do you say that? Angiography.
Angiography, yes.
Is the factor, as in factor graphs? Are there factors and nodes?
Mm.
Is it a bipartite graph?
I encourage you to look up the details in our. That's kind of what I overview.
Looks like bipartite.
Mhm.
That's for something and these for something else. How do you incorporate priors?
I'm not sure. To get back to you.
I'll go, thanks.
Florian,
This is more, I think, a general OCT question. Can you elaborate a little bit on what are the criteria for the selection of an optimal light source in terms of bandwidth and in
Yeah.
terms of center wavelengths? Because I imagine this also varies with the tissue that you're interested in doing, and you basically want to be like with your devices as flexible as possible.
Yes, yeah, that's a very important consideration. There's a consideration the answer depends on both the sample that you're imaging and on availability of light sources. So when you're imaging biological tissues, there's optimal windows where you'd like to be. So the 850 region is very popular in OCT because of that and because of availability of light sources. OCT initially started kind of borrowing a lot of components from the optical communication. So there's 1.3 micron is also a good window. And 1 micron is also a good, although there's not as many components available. Now, in terms of the bandwidth of, the broader, the better. There's also different types of performing spectral domain OCT. What I've shown you and what we do is using the broad bandwidth and then doing a detection with a spectrometer. A newer development is using a concept of swept source OCT, which uses kind of monochromatic light that's swept across the bandwidth of interest. So the detection is just a photodiode. And this has advantages in terms of the speed that you can obtain. So, and again, availability is very good in the optical communication network. Bandwidth, not as much, maybe the one that we're interested in for biological. And right, so, and then the other parameter is how deep can you image. So the longer the wavelength, the better the penetration. You give up on your lateral resolution. And for us, the original goal was really getting the best lateral resolution we could get. So it made sense to go with a lower shorter wavelength.
anyone else? Yes, Mr.
Hexagonal cells that you have photographed, these were on the inner side of the cornea.
That's right, yes.
Do they grow all the way to the top, or do they have a certain range?
No, they're a single layer of cells in the back of the cornea, and they're responsible for kind of keeping it clear. Let me see. There. So there's kind of 5 different layers in the cornea. There's the epithelium, which has this, this type of cells. There's bomal layer, there's stroma, which is the majority of the cornea. There's descemet membrane, and endothelium is just a single layer of cells. And when the cornea is transplanted, there's different procedures. So originally they used to transplant the entire cornea, and then more recently they've advanced the transplant technique. So they're only transplanting they call it DMEX, so descemet membrane endothelium keratoplasty. So they're just extracting this portion, and there's more detailed, other type of procedures that are getting finer and finer. So that gives better outcome for the patient. And that really shows that that is the really important layer for maintaining the health of the entire cornea.
About stroma, not one of these endothelial or epithelial cells. Is that correct?
I'm not sure. I'm not sure what. I'm not sure.
Layer from the top, and then remove something, and then put that layer back. So I think that would be the epithelium, and then what they remove is the stroma.
Any other questions? Okay, well, thank you, Cristina. Thank you for attending.